Welcome to today's webinar, Workforce Cost Containment Strategies Beyond COVID. This is Rosalind Lewis, HFMA's Technical Analyst, and I will be moderating today's session. Now it is my pleasure to welcome today's speakers. Rita Berry is the Director of Nursing Clinical Support Services at Penn State Health. She is responsible for providing strategic direction and leadership for staffing systems and strategy within the Department of Nursing. Rita serves as a resource to manage daily operations of clinical staffing with the expectation of long-term financial savings through enhanced utilization, scheduling, and deployment of staff. Prior to her current nursing leadership position, Rita spent 38 years in various nursing leadership and clinical roles within the organization. Liz Lustgraaf is the Manager of Workforce Optimization at AMN Healthcare. Liz is an experienced AMN Healthcare workforce advisor, supporting more than 650 facilities across the continuum of care for inpatient hospitals to ambulatory and surgical outpatient centers. She provides strategic oversight to executive-level healthcare industry leaders on how to empower the future of care by building a sophisticated and sustainable workforce plan. And with that, Rita, I'll turn the presentation over to you.
Good afternoon, everybody, and thank you, Rosalind. Before I start, I want to start with something that I do every single day of my life to my 3 adult children. I always start with a joke of the day. I found this joke this morning and thought that it was perfect. So, why do bunnies like math so much?
Why, Rita?
They're always multiplying.
Okay, that's a pretty good one, Rita, and well played for our financial leaders on the line. Hi, everyone. I'm Liz Lustgraaf, your co-host with Rita, and we are honored to be here today and share with you the journey that Rita and I have been on for, Rita, almost a decade when we were talking about doing this together, that we've been working together. And in that time, personally, we've seen 3 presidents in office, watched 2 royal weddings. Yes, I'm a total nut for the royals. And seen the share gig economy like Uber and Airbnb, that was just entering the market when Rita and I started working together. And as we all know, Uber and Airbnb kind of own the market anymore. So beyond those type of engagements, personally, Rita and I have seen engagements and weddings and grandchildren, but that's not why we're here today. While I'm sure you would love to hear about our personal lives, we are actually here to show you how over the last decade, our partnership has really allowed Penn State Health to build a sustainable workforce plan, providing equality to their staff that results in not only strong staff satisfaction for what their workforce conditions are, but it also provides a really healthy and sustainable financial results. So today the objective is, I'm going to start by giving just a brief introduction of some industry insights that we think you'll find relevant as we're coming into what we hope is endemic of this interesting 2-year ride that we've been on. Then I'm going to tee it over to Rita, and she's going to share how specifically Penn State Milton S. Hershey Medical Center navigated staffing during the pandemic. And then she's also going to show you some specific data that they actually use to make informed workforce decisions. I'll come back and share just a little bit more industry statistics around the talent landscape in healthcare. And Rita will close us out by sharing 4 industry strategies that they're currently working on implementing. So let's get started. All industries were impacted by the pandemic, but healthcare was one of the top 3 industries impacted. And as we enter what we hope we're hearing is the endemic, we want to talk about these 4 solutions we believe every healthcare organization should start to consider. First is revenue enhancement. As the pandemic started around March, April 2020, we know that healthcare organizations were operating well below 50% of their previous norms or the pre-COVID census. We know elective surgery shut down. We know the revenue that generates for a healthcare organization with those elective surgeries. The results that we're now seeing is that tens, if not hundreds of millions of dollars was lost per month while we saw those decreased volumes. As finance leaders on the line, I'm confident that you've been asked to make this a key priority to determine how to recoup this lost revenue. One way is to have some cost containment initiatives that you can focus on. And as I said earlier, we're really starting to enter what we hope is the endemic, which is both a really big sigh of relief of just getting past this unprecedented time of a pandemic, but it also comes with a little bit of a sigh of concern, because the fact is that operating costs are simply more than they were pre-pandemic, or what we used to call the norm. We don't know exactly what that new norm looks like, but we know that it's starting to cost more money than it used to. So finding opportunities that you can action on quickly is key. Recently, I've seen an organization that I work with focus on some low-hanging fruit opportunities. For example, what we call reducing incidental work time. By definition, these are really those hours that are worked in excess of their shift that's scheduled. Usually you can correlate this to like a staff member goes in for their shift, their workload is really intense and they had to skip their lunch break. And so they're getting paid for that 30 minutes of lunch that you were expecting them to take a break for. While it can feel a little inconsequential to have a staff member miss their 30-minute lunch and get paid for it, when it's consistently happening across the organization, the bottom line is really impacted. A recent example with one of my healthcare organizations, a 12-facility system, they found that if they could just reduce 20% of what they experienced in incidental work time in 2021, they would save upwards of $5 million. The really special thing about this type of project and initiative is not only the cost containment that you can apply, but this is also a really two-folded opportunity, because it's a huge cultural win to the nurses, because it helps them consistently take a break for their lunch. And their shifts, we know, have been grueling with the pandemic and the intensity of the patient loads. It also really ensures that they're getting out of work on time. That's the other biggest component you'll see in incidental work time is, maybe they were so busy they didn't get their charting done for the day. And so now they have to stay an extra 30, 45, 50 minutes at the end of their shift to make sure that they get that charting done, hand it off to the next team coming in. So putting initiatives around that type of incidental work program can not only be a large cost savings and cost containment, but it can also focus on the cultural mindset of the workforce. Next, when we think about workforce and operations flexibility, COVID actually had a positive impact too, because it really forced healthcare to think differently. And we found that it actually accelerated an organization's ability to share their own resources across the system in ways they've never done before. Because staff and the entire organization, I think we all can safely say the entire global community really understood that it was all hands on deck, and healthcare being frontline heroes was a large part of that. Healthcare organizations need to start seizing the moment to action on the shift of this mindset and how they can make changes now that we have opened that door to thinking about how we're going to staff and schedule differently. In fact, we've had a few of our organizations that we work with that are creating their own internal float pools, or in some cases, what they're starting to even call internal agency resource teams. We know that, agency and travel companies provided such a relief to healthcare to provide additional direct care hours. But it's unlikely that healthcare organizations can make that a sustainable platform to continue. And so these organizations are really trying to take that concept of, we know our staff, like that flexibility of going to different areas, and they're really starting to listen to their nurses and what type of programs would help them. And what is actually the last strategy that we really encourage you to think about, which is talent acquisition and retention, which we know was heavily impacted. Most hospitals were just doing their best to simply try to get through the pandemic. Now that we're in the aftermath of the pandemic, we're really starting to just scratch the surface to see how severe the mental health crisis is and what the impact is on the pandemic, especially for our healthcare leaders. It's more important than ever that we find ways to listen to those frontline leaders and find out what matters to them in their talent acquisition and retention. These are 4 things that we encourage you to think about in your organization and that we're going to elaborate on throughout the presentation. But we are going to ask you our first polling question. So if it will be a priority for healthcare organizations to A, rely on a range of strategic and tactical initiatives, B, develop plans that can quickly pivot as new challenges and priorities arise, C, implement strategies to recoup revenue in order to return to pre-COVID levels, or D, all of the above. If you haven't yet, please take the time to fill out the polling questionnaire that's on your screen with your answer. As a reminder, these answers are required for you to receive your CPE credit at the end. And we look forward to seeing your response. Melanie, I see it didn't pop up for you. Thanks for commenting. And we have closed the poll. And the correct answer, Melanie, you were spot on, is D, all of the above. So it's important to think about things in an integrated approach. Throughout the pandemic, we were challenged to innovate and action quickly just to get through the unprecedented situation. And y'all, we really accomplished some amazing things in the healthcare sector. So I am going to turn it over to Rita now to share her story on how they navigated the pandemic.
Thanks, Liz. So every time I tell this story, in the very beginning, it was very hard to tell this story as a nurse leader that entered the pandemic really feeling like we had what we needed, but not really knowing what we were looking at. We had a great opportunity here at Hershey in 2015, where we developed an Ebola team, and we actually traveled to Nebraska and looked at the University of Nebraska and their team. And I was charged with putting together a staffing model for this team. So in 2015, Hershey Medical Center received an Ebola treatment center designation. We trained 40 nurses who volunteered for this training and worked with physicians throughout the year in 2015 and into 2016. We did many tabletop exercises, we did simulations, and we trained every 3 months. We continued that training, not really realizing what was going to happen to us in 2020. So when we started receiving our first COVID-19 patients, they were immediately taken to our surgical intensive care unit. We commandeered our nurses, who were now called emergent special pathogens nurses, and we commandeered them to the ICU to really be a support system to those ICU nurses. Once we had too many patients in that ICU, we opened up another unit, and all 29 nurses that were left on this team came together and staffed and took care of COVID patients. So our other nurses were seeing other patients, but not COVID patients throughout the rest of our hospital. We didn't know at that time that what other organizations were doing, because as you can all imagine, and I think you were probably all feeling it too, we felt like we were sucking from we were drinking from a fire hose at that point in time. So it was, all hands on deck, and we were just trying to move forward and understand, what we were dealing with. I was so proud of all of these nurses because they made it very easy for me to make a staffing plan. They were flexible. They said that they would work extra hours. We ensured, I think my fear was that something would happen to one of these nurses. But they had great training. None of them ever ended up with COVID during this time frame. To this day, they are still a great team. They taught other nurses in the hospital things that they needed to know about COVID-19. And what happened was that team approach that you hear about and that you understand is so important right now to survive really became the benchmark here at Hershey. Other nurses wanted to work on the COVID unit. I know that sounds like crazy, but that's what happened because this team of nurses were so fabulous. What we knew when this was all happening to us, and even when we had a lull of COVID patients before the second surge happened, it became very clear to us that we had nurses that were tired, that had moral distress, and that we always knew that we needed a workforce plan and strategy in place, but we didn't know how hard it would get as the world turned. So the next thing, and Liz, can you go to the next slide, please? Thank you. So when you talk about strategic workforce planning, this is really the model that we put into place. We knew before the pandemic that we always needed to have a strategic workforce plan. And when you talk about a workforce plan, the same words come out. You need to make sure that you have the right number of nurses. You need to have the right skill of nurses. You need to have the nurses in the right place at the right time. Those are typical verbiage when you talk about a strategic workforce plan, but there was so much more to it. And before the pandemic, we had started to create this workforce plan. And when the pandemic hit, we realized that we had to really get this plan out, but it would become harder and harder. Within the plan, you need to define goals of an organization. And a lot of times we look at the benchmarks and we develop our budget around those benchmarks. But we really need to talk through, now what are we looking at? We need to collect data and review the data, but we have to review the data not only with our financial liaison, but we have to bring in the staff and review it with the staff too. I cannot do my job without partnering with my financial liaison here at Hershey. I meet with my financial liaison every week, and every Monday we have a meeting and we go over things. The other thing that we do at Hershey is we forecast. And that's a word that's used a lot with analytics, but what we do is a simple forecasting of looking every week at the number of FTEs we have and what our fill rate is. And we ask our managers to predict things that could occur on their units, like pregnancies, an emergent FMLA, somebody that needs to go out for surgery, a nurse who's going to school to become an NP. And we ask them to predict out what it could look like if their nurses handed in their resignation. And that's how we've always gone forward to plan. It's a forecasting tool that is just really an Excel spreadsheet that the nurse managers religiously keep up. And then that way we can go in and look at data and then have good conversations. We look for gaps in schedules and we ask the why. We're always asking the why. And then, as I said before, it's so important that when we look at a workforce plan that we're actually asking questions to our frontline staff because they really actually give us the best intel. The strategy then leads to our outcomes. And this is just a quick slide that I pulled looking at the fiscal year 2019, 2020, and 2021. The red is our GNs and what our goal was for GNs, how many GNs we needed in our organization. And the blue number is what the external hires were. So experienced nurses coming into our organization. And I think what this slide shows is that it's clear to us that our GNs are increasing and we need to increase our GNs because we're finding that we don't have as many external hires or nurses in our pipeline as we have seen in the past. And I think there's many reasons. I do think that the pandemic has really caused havoc on us. And some of the things that Liz brought out in the very beginning, they're all of that. And I do think that we don't even know what, when we talk about moral distress is so many different things to so many different people. So we really need to plan as we go forward what our workforce strategic plan is.
Thanks, Rita. Really fantastic overview of how you handled it. And it sounds like the pre-thought that you all had to have that strategic plan really set you up to navigate the waters as you were experiencing them. So as we think about the next element that we really want to start sharing with you, it really revolves around analytics and flexible scheduling systems. And, you know, we think about the scheduling tool that provides trusted supply and demand data to ensure that you can use that data to create prioritized action plans that help streamline many processes. And Rita just introduced that topic to you. So as finance leaders in your organization, you're probably being asked to do things like find ways to reduce those expensive costs of staffing, overtime, agency incentives. How are we going to get back to containing our costs? And I challenge you to open your mind and start thinking about, as Rita just shared her story, you know, how are you utilizing your scheduling tool and data inside your organization? How frequently are you meeting with your nursing operations and HR leaders so that you can really use that data to have a robust conversation so that you can think about what streamlined processes do we need to focus on? Is there a way we can optimize our workforce plans? I shared earlier that the pandemic highlighted more than ever how important it was to really maximize the flexibility of your workforce. You know, our partners like Penn State, you know, have really used this scheduling tool and cross-departmental task force to really sit down together, talk about the data. And they're able to really clearly identify what's their supply versus the demand trends that they're experiencing. They know exactly where their greatest needs are. They know exactly what units are going to have trouble, not 1 month, but sometimes 2 months in advance, all the way up to 6 months in Penn State's case. And so they're using this data to the best of their ability so that they can make informed decisions. And they're really making sure that they, in a cost-effective way, are prioritizing what's going to streamline our processes the most and what's going to produce some outcomes. And then they pivot and course correct as they need to. We don't always get it exactly right the first time, but when we're using data, it allows us to really have a more factual conversation. And when we're working with nursing operations, we need to ensure that we're listening to the feelings side while also ensuring that we're respecting the data side of the story. So the next polling question for you all is true or false. Having access to industry relevant data does not help to streamline processes, especially when it comes to something as critical as workforce planning. A for true or false. Okay, polling question closed, and the answer is almost 92% success rate is false. Okay, I'm going to turn it back to Rita now that we've really teed up the conversation of how important data is. And Rita's going to walk you through exactly a scenario of the data that they're using to make these informed, prioritized decisions.
Thanks, Liz. So this is an example of an executive summary that I put together for nursing units here at Hershey Medical Center. And the question always comes up, well, when do you do an executive summary? Any unit that I see is at a 15% vacancy, we actually get together with the manager, the vice president of that division, nurse recruitment, and the financial liaison, and we talk about data. So we're able to pull many things out of our staffing and scheduling program. So what I do is I try to put this together for the nurse manager, but I need the nurse manager in front of me to tell me their story. And so that we can ask specific questions of how they're really feeling. It's so important. So this is our medical intermediate care unit. They actually had a vacancy greater than 20% in the last 2 months that this was written. They were then at 24% when we came together. And what I do is I always look at the vacancy rate by skill. So I'm pulling out, if they're a unit that has PCAs, I'm pulling out their PCAs, but I'm also pulling out usually their RNs in charge. That's the main thing that is on. This is a unit that does not have PCAs, so I'll be showing you just the RN in charge. We pull out their source report, their number of patients by hour of day, and their non-productive time, and we talk through this. So the first graph that you see is their open positions. And having nurse recruitment in the room helps us make sure that we're aligned, that the nurse manager is telling us how many open positions we have, but that nurse recruitment is saying, yes, we have these open positions posted. In the very beginning, we had gone to a new system, and what we noticed with these meetings is we were missing some of our open positions. The other thing too is that sometimes my data is different with open positions, because one strategy is that a lot of times you will hold off posting your open positions on day shift, but you still need to account for that vacancy because it's easier to fill a day shift position than a night shift position. And when you're in an organization where night shift nurses can move to day shift, you want to make sure that you're securing your night shift since it's harder to fill. So as you can see, this is kind of a dismal picture of how the vacancy rate is going up and not down. And then the other thing too is it shows us the staffed hours if they're aligning with the demand on the unit. And as you can see, those staffed hours are shorter than what the demand is. And our demand has to do with our staffing plans that have been placed into the system. So you can see that their average fill rate is 90%. So then here's the question, is 90% okay? Because on some units, it could be. But the big question to the nurse manager is, what does 90% feel on this unit? What are your stressors? Do you need to be at 90% filled, or do you need to be higher? And I call that the sweet spot. So I'm always asking the manager, what's your sweet spot? And there's lots of ways to do this. You can break this down daily and look at your demand hours and what you've aligned to, and then tell the story. And sometimes when managers are having a hard time telling the story, I ask them to do that exercise, and it becomes very clear what's then happening on their unit. The next slide has to do with the source report. And as you can see in this source report, it's done monthly. This is a picture of the charge and RN and how much core hours they have. And core staff is the nurses that are assigned to that unit and are hired into that unit. The site pool is the float pool. So how many hours of float pool you've given them, how many hours of overtime and extra time. So overtime definition for me is in a week, anything above 40 hours, and extra time is anything above their FTE, but below the 40 hours. When we talk about site pool, overtime, and extra time, and also agency, you can see that agency is there, although it's zero here. The reason why it came up in this discussion is we were going in the direction of probably needing agency nurses. And in October, this unit did end up getting agency nurses. The next slide shows the average daily census. And why is this important? It's important to know your volume. And if you can look at it by day, it helps units staff appropriately. So you don't hear nurses say, we need to be at 14 nurses all the time. You start hearing, you know what, we can ebb and flow. We absolutely have to have our highest number of nurses on the weekends because our unit gets really, really busy on the weekends. And you can see that by the average daily census. And then I always look at non-productive times with people really as an opportunity, a question of, does that represent your budget with non-productive hours, or is it higher on some months? And why is it higher? Could we be a little bit lean with the council time? Should we be leaner with our education time? Or did something happen? What's the variance? So those are the major things that we look at. And Liz went to this next slide, building a culture of resiliency. You build a culture of resiliency when you make sure that your frontline staff are involved in these conversations, that you take the time to go out and listen. A lot of times I'll bring Jana with me, our financial liaison, and we'll talk through why the benchmark on a certain unit is this. And when she hears the nurses talk about her patients, she's able then to make the case for, more FTEs. Or we have to have the hard conversation of saying, you know what, we probably don't need that amount of FTEs. We probably need to stay at this benchmark. So it goes both ways.
Mm-hmm. Rita, I love that story. I mean, cross collaboration between nursing operations and finance is just such a key to success at building a culture of resiliency and a sustainable workforce strategy on the finance side of the equation. So thanks for that scenario. As we transition into this building a culture of resiliency, you see the word turnover on the slide, and that's not new news, I'm sure, to all of you, that turnover is costly to any organization, but especially healthcare organizations. And the pandemic certainly had a negative impact on the turnover rates that we're seeing. Simply put, in the industry, the demand for positions is exceeding the supply of nurses that are available. And relying solely on travel nursing to come in and, save the day is just, it's not an adequate strategy to address these rising levels of vacancies. And we really need to start to think about how we can build the culture of resiliency in our own organizations. So when we think about the talent landscape in healthcare, turnover is the highest rate that we've seen in the last 5 years in the healthcare sector at 19.5%. I think it's really important, though, to note that this turnover concern includes key components like physicians, executives, CEOs. We've seen more turnover in those spaces than ever before, and they're so foundational to the strategic plans and visions of the systems that we work in, that it's causing a new wave of uncertainty when we see exiting of executives and new executives coming in, and is it going to completely change the DNA of who we are and what we're focused on, and it leaves us asking a lot of questions. Some of the themes that we hear as why people are starting to leave or have been leaving is just the increased responsibility because the shifts in the working conditions were grueling during the pandemic. As we've talked about, I mentioned a couple times, fatigue and mental well-being is real, and we're just scratching the surface to understand what that means. For a lot of nurses, they're saying that it's the low wage jobs and that they don't feel that there's a lot of opportunities for career growth and higher paying jobs elsewhere. I see a comment about the, mandating of vaccines and that driving turnover. We certainly saw that in the industry. As we all know, nurses are key to drive organizational culture, and Rita really hit the nail on the head when she talked about how important it is to go and hear their story, because sometimes their story helps us think about what the data is saying differently, and we can find compromise and collaboration that really helps us solve for it. So not only some of the things that I'm mentioning, or what we're experiencing, but factors that we already knew were happening. 86% of baby boomers plan to retire. 42% of nurses report burnout. And the supply is just less than the demand experienced by a ratio of 4-to-1. As you all know, these statistics really sadly aren't that startling to us that have been in the healthcare sector anymore, because it's the landscape that we've been navigating for years. The pandemic simply expanded that gap in the problem. So what can we control? And I see the comment on how do you combat that? Let's talk about that. Let's talk about what we can control. How can we start to close the gap? So I'm going to turn it back to Rita on what they're focused on.
So here's the bad news, okay? So I'm going to give you my dirty laundry here, okay, so that you can see it. You can see what Liz just talked about. Right now, fiscal year to date, we're at a 25% turnover rate. It's the highest rate I've ever seen in my 38 years here at Hershey. It's scary. And having a workforce plan is a must. We have to be consistent, and we have to keep moving forward so that we can rebuild our workforce. And there are lots of factors, the mental and moral distress, nurses feeling that they don't do enough, early retirement that Liz has alluded to. And also, we here at Hershey saw many of our nurses take travel positions because the rate of a traveler was just so high. And many of them, I can't pass this opportunity up. I'll go for 13 weeks and I'll come back. So it really was devastating, to us. But we need to pull our bootstraps up, and we need to all figure out strategies that we need to do. So the next polling question is, turnover rates are highest healthcare has ever seen in over how many years? A, 3 years, B, 4 years, C, 5 years, D, 6 years, or E, 7 years. Melanie is correct again. So I'd like to share with you strategies to drive this engagement. Four things that Hershey is doing. Clearly we learned that team-based staffing models are important. We kind of threw ourselves into that, and it has to continue. One of the struggles that we see is because our mental health patients have increased dramatically, we are pulling our PCAs from our med-surg arena to cover those one-to-ones. So we did a deep dive into our PCAs, and about 6 months ago, we did an analysis after speaking with nurse recruitment and the nurse managers that had PCAs. We immediately looked for 12 more PCAs in our flow pool. We do have PCAs on our flow pool, so we immediately wanted to increase that flow pool. We also did a drive with the managers to hire any open positions. So we are still working on that drive today. But every week I get a report from nurse recruitment and I shoot out a morale booster of, let's get these PCAs hired. Let me help you interview. I'll do anything in order to get all of our PCAs hired so that we have a full complement and that we can start having PCAs on the floor to support our nurses. Another idea that really came from these meetings that we had and sitting down with our IR department and also our neuroscience ICU manager was we have had travelers in our IR for 3 years now. Even before the pandemic, we had travelers, but now it's really 70% of the staff is travelers, which is really hard in a small unit. And so we came up, one of the ideas that we sat around the table and talked about was, why don't we have neuroscience ICU nurses also work in CVIR and NVIR? You kind of do two things here. You're giving nurses opportunities. They already are taking care of these patients that are having these procedures down in IR. So you're giving them an opportunity to really understand the procedure that the patient is having and be involved in that, plus work on the ICU. So they would be a 1.0 FTE. Their 12 hours would be in the ICU and their 8 hours would be down in IR doing procedures. The other thing that this does for you is the complaint of many nurses in small procedural areas is, I love doing these procedures. I don't want to take on call. So if you have an in-house nurse working in IR on night shift, she can be up on the ICU helping, but then if there's somebody that needs a procedure done emergently, she's ready to go because she's already here. And you're decreasing the on-call time that you need. So that was another strategy that was brought up. We're trying to put that in place so that we can decrease the travelers that are actually in our IR right now. Early retirement. Well, really, who really wants to retire? You need a hobby. You need something to do. So we're just starting this program. We've gone through, it's been accepted with administration. It's the emeritus program to maximize our highly qualified nurses that are getting ready to retire. We are talking to these nurses and asking them if they want to stay on part-time or 1 day a week where they're helping to educate our new nurses. We don't want to lose the value that they bring and the knowledge that they have. So this program is just getting off the ground. We actually have a nurse manager who is contacting, all of our nurses that are getting ready to retire or who've said that they're going to retire. And we also brought back some of our retired nurses during the pandemic to do COVID testing. So that's how this idea ballooned to today. And the next thing is certainly retention and financial incentives. We did give our nurses a retention bonus. It was $1,000 in January. It's $7,000 in July and $7,000 more in January for a total of $15,000. And we also do incentive bonus shifts as well. So those are just 4 examples of strategies. My recommendations is that any idea is a good idea. Sometimes the ideas that we had 5 years ago need to have the dust wiped off of them and brought back. So any idea is good, and we should always zero in on our nurses and our frontline people to help us make those ideas happen. I think we go to a next polling question. True or false? Team-based staffing models have been shown to increase nurse satisfaction and improve communication. A is true, B is false.
Well, that really concludes what we have prepared for you all today. And at this time, we will open it up for questions.
Thank you. I'd like to, at this time, invite those listening to enter your questions in the Q&A box located on your computer screens. And we will take our first question now. Wondering what staffing and scheduling software Penn State uses?
Yeah, Penn State uses SmartSquare. It's an Advantis product.
All right, and our next question is, what is Penn Hershey doing to replenish the pipeline of RNs?
Yeah, it's a great question. We are constantly, looking at data. We certainly are looking at those 4 programs that I talked about. We did have to use a significant amount of travelers that we have not had in many, many years. And we're what's great about using our travelers right now is they tend to give us time where they're constantly extending their contracts. So we're able to then, maintain educating our new grads. We also realized how important it was to increase our new grad number. So we used to do grad orientation 4 times a year. We are bringing graduate nurses in every month. So instead of waiting for a group of grads to pass their NCLEX, if they pass their NCLEX in May, they're going to start in May. If they pass their NCLEX at the end of May, they're going to start at the beginning of June. So we've increased our orientations for our new grads in order to continually have nurses coming in and being oriented.
Okay, and we have a participant that says that works with that works in a health department rather than a hospital setting, and would like to know what a PCA is.
A PCA, I'm sorry, is a patient care assistant is what we call them here. We also have patient safety companions here at Hershey that also do our one-to-ones for our suicide precaution patients.
Okay, and our next question is, in the team-based staffing model, what percent is RNs and which roles make up the remaining PCA?
So that's a great question too. The percentage of RNs, usually on a med-surg arena, our ratio is 4 to 5 to 1. There are times that we end up being 6 to 1. And we only do that when there are call-offs. And it's usually our night shift. And each wing, there's 48 beds on a wing. Each wing has 1 PCA. But what happens to us, depending upon the number of one-to-ones, is we may have to pull one of those one-to-ones, one of those PCAs, so then a wing ends up with only 2 PCAs. And sometimes when things are really bad, only 1 PCA. So that's the heartache. So I don't know if I had to tell you what percentage, I'd have to sit there and think about, usually it's probably 75% RNs, 25% PCAs, but on a bad night, it's, more RNs and the PCAs leave that med-surg arena to go do one-to-ones elsewhere.
And Rita, to kind of tag on here, I mean, when you think about go investigate the scheduling tools that you're using inside your organization, there's likely a plan that nursing operation and finance have put together that says, this many patients, here's how many of each skill I need. And so, Rita's team really builds that plan in the scheduling tool. And then the scheduling tool has an automatic feed from their EMR system to know exactly how many patients. And it's just helping them clearly see exactly what supply and demand they're experiencing, and adding the PCAs in at the different, depending on where they feel they need additional support, maybe not as fully skilled as an RN, but those extra, resources there help the RN stretch how many patients they can see because they have the support of a PCA. Those are the types of team-based scheduling that we see our organizations that we work with really start to focus on.
Okay, and our next question is, do you see any end in sight to the high turnover rates that you are experiencing?
So I want to answer that question by saying I hope so.
Mm-hmm.
What I do see right now is the rates of travelers have dramatically decreased, which tells me that there is now a turning point. I also know that many nurses that have left our organization to travel, we have many nurses coming back. So I also think that that's a picture of, I'm hoping we're going in the right direction.
I would agree, Rita. We're seeing the data show us that the need for travelers' requests have declined. And so I think now is the time to build that culture of resiliency that is our funnel. But these nurses, we need to listen to them to know what's important to them in that, not only retention, but what's going to attract them to come to your organization, and having those marketing campaigns and knowing how to represent yourself and ensure that you have a good work environment for your staff is going to be key on where these nurses select.
All righty, and let's see. I think we have another question. How can systems reduce the amount of overtime and premium pay?
So one of the strategies that we've used here at Hershey is we analyze our float pool to ensure that we have the right number of floats within our divisions. And here's another strategy. When you feel like you need to pivot because you may have an ICU that is losing nurses, you then look at your nurses who are involved in IMC care, and you go to them and you say, I have an opportunity for you. How would you like to orient to the ICUs? So you give the opportunities to the nurses to engage new skills and to build their knowledge. And it's interesting how many of the nurses will want that opportunity. So you're constantly analyzing where you need that float pool and contingency. The other strategy is to use per diem nurses and to really build that piece of contingency that may not be at a premium rate for a long period of time, where they swoop in as, kind of like the white knight and take care of some of the areas that have gaps, and then they swoop out and they're off for a week, and then they may swoop in and pick up one shift. So it's all of those things that you're constantly looking at, and you're having good conversations in a central staffing office to recruit people.
Okay, I think we have time for maybe one more question. What steps should a healthcare system take to ensure the mental health of its clinicians?
I'm gonna highlight the story I talked about with the incidental work time. That's one component that is such a twofold type of initiative and priority. And I highlight it because perhaps, Rita, you can share some of the quality work that you did when at Penn State, when you all made this a key priority, and talk about some of those outcomes and the feedback that you heard from nurses that you were really able to embed, that will really help gather both their feedback and determine how to course correct those in the future.
Yeah, I think for me, the answer that immediately popped into my mind is we have to be present and we have to be active listeners. And there's certain things that when I round on units or when I'm talking to nurses, we have to give them the chance to say what's on their mind and really listen to that. And there have been times that I've sent a note to a nurse, or I have gone to her and said, hey, do you want to take a break? I'll watch your patients, or I'll get somebody up here to watch your patients while you go and take a break. I mean, just being present in the moment and listening, I think, is probably the most important thing. And a lot of times I'll have feedback from nurses, thanks for listening to me. And sometimes you have to do the hard thing. When you know that they're really struggling, you have to say, you know what, I want you to go home. I want you to go home and take care of yourself. And when you're okay, call me on the phone and then come back. And that's a hard decision to make because you could already be short-staffed. But to me, when you see that happening, the nurse will come back to you and they will give that time that you may have had to find somebody else to work. They'll give that time back to you twofold because you just cared about them. So I think that that's my answer to that.
Well, thank you. And with that, we have reached the conclusion of today's webinar. I would like to thank our speakers, Liz and Rita, for presenting, and AMN Healthcare for sponsoring. We hope that you have found the presentation informative. Thank you for your participation and have a great day.